Hi, good afternoon. My name is Pony Cheng from neuromeridian.net. I'm joining you today from Toronto, Canada. Welcome to this week's show for the American Acupuncture Council. My guest for today is Jamie Chavez. Jamie Chavez has been a licensed acupuncturist in California since 2002, and he received his master's in traditional Chinese medicine from five branches and has participated in internships in Beijing, China. He specializes in the treatment of work-related injuries. He is currently the head acupuncturist in a prominent Bay Area workers' compensation clinic and works alongside medical doctors, physiotherapists, and orthopedic surgeons. Jamie is passionate about the art of physical examination and integrates multidisciplinary approach in the assessment and treatment of MSK pathologies. Jamie has been an instructor in several Bay Area acupuncture schools at both the master's and doctoral level. It was during this time that he discovered his passion for teaching. Jamie has had the honor of introducing acupuncture to medical residents who periodically shadowed him for clinical rounds. He has been a guest lecturer for Stanford's Physician Assistant Program and has been actively teaching physical examination skills to acupuncturists in hospital settings. Jamie continues to find joy in spreading the word about the effectiveness of acupuncture. Also, you may, in case you haven't know, you don't know, and you should, Jamie is also the admin and founder of the Dao Facebook group, which is Discussions Acupuncture Orthopedics. I've been waiting to interview Jamie for a long time now. He's a busy guy. Our schedules just never coincided. So I'm very excited to finally be able to make that happen, and very much looking forward to this interview. Thank you very much for joining us, Jamie.
Thank you for having me. It's a pleasure.
Yeah. So you are the very passionate about physical examination, and I know a lot of people don't do that, and so for those of us that probably need a little bit of motivation, or what is it that you can tell us in terms of what makes physical examination so important to clinical practice?
So, in general, I think the physical examination is essential to all of us, no matter what style of acupuncture we practice, especially if you're treating any kind of pain or injuries. Um, it's a way of holding yourself accountable so that you can prove or disprove your own thinking about what you are, you know, thinking is going wrong with the patient. So someone comes in with a chief complaint and you gather the data and you think something's going on, but you have to hold yourself accountable. You have to keep yourself in check and try to eliminate your own bias and basically try to get better at gaining clinical experience because we're all researchers in the clinic. And so this is our way to do research. So we want to find things that are reproducible, repeatable, and physical examinations that bridge, for me.
That's great. I have heard you talk about. I've heard that you really enjoy teaching through acronyms and mnemonics, and
Mhm.
it's just we learn by association, so it's good to have something to kind of associate things with. When it comes to physical examinations, is there any mnemonics that you think would be helpful for us to become more comprehensive in our intakes or in our assessments?
Yes, there's a ton of them out there. I mean, I've gathered and tried all these different ones over the years, but none of them really crossed over and applied directly to an acupuncturist.
Mm,
So, there
yeah.
was missing pieces or the order was not right. So I came up with a mnemonic horse, HORSE, and I've been sticking with that one ever since. And I can explain a little bit about what each of those letters means. The H is the history of the patient. So that's, their past history, which is the things they fill out on the initial intake form. But then there's the present history, which is, regarding their chief complaint. What brought the patient into the clinic to be seen today? Let's get all the data regarding that specific topic. And then the O is the observation. So what do you see from the patient? And that's now we're getting into the physical exam skills. So what do you see when you look at the patient? And that usually begins the moment lay eyes on them when they're in the waiting room, when you walk them back to the treatment room, and then there's other key pieces that you're going to look for depending on what they're coming in to be treated for. But observation is really important. I'm very passionate about observation because it's so fast and you can see so much if you know what you're looking at. And a lot of times we see things, we just don't know how to interpret it. So that's something I've been really passionate about over the last couple years, and just really diving deep into just diagnosing by looking. The
Mm-hmm.
R for horse is range of motion, which is essential. It's one of the most important things that anybody can start using right away because it's so fast and you get so much data from the patient. There's different types of range of motion. So there's active range of motion, there's passive range of motion, there's resisted range of motion. Resisted
Mm-hmm.
range of motion could be like your manual muscle tests, right? So it's all in that frame. Passive range of motion could be your muscle length tests. There's many different ways to look at that. And then the S is the special tests. So that's the orthopedic tests. Some people call those provocative tests because you're trying to basically tease out where the problem's coming from. And then the E is explore by palpation, hands-on, diagnosing by touching. So each of those, contributes to the HORSE acronym. And that is the order of operation for me. So we talk to the patient first. And then when it comes to physical exam, we look at them, we have them go through a movement assessment. And that could be active, passive, or resisted, or all of them at the same time, check each one individually. And you would want to do it in that order. So active range of motion is first because you want to see how willing the patient is to even move. Right away, you're already,
Mm-hmm.
gauging where they're at when you want to do other tests down the road. And then you would do passive next, and then you would do resisted last because resistive could be provocative. It could cause pain in a patient. You
Mm-hmm.
always save painful tests for last because if you cause your patient discomfort, they may say, okay, I don't want to do this anymore, right? Like, let's stop the
Mm-hmm.
exam here. So
Yeah.
if you provoke their pain, it also skews your results for everything else you check because now they're,
Right.
they feel a little discomfort. Now everything you check is, you don't know how valid it is. And then for
Right.
us, we're acupuncturists. So what are we going to do before we stick a needle in? We're going to palpate. So why not do that last? And that in itself, palpation is provocative. It causes pain in patients. So definitely we want to save that towards the end and then go right into our needling.
Hmm. Okay, I like that. It's like from the assessment, the palpation, diagnostics, and it goes transition smoothly into the actual needling component.
Right.
So it's very seamless. I've heard of you mention something called the ABCs before. Is that also a type of assessment, or is that something different?
That's another acronym. So like you were mentioning, I love I love mnemonics and acronyms, right?
Yeah.
Um, what you see a lot of, and with social media and things, you kind of get a sense for how well people are able to extract data from their patient. But the H in horse is the history, and I have an entire course just on how to do, a history. We could talk about that all day. But to keep it really simple, there's key components that you have to get from your patient when they come in, and there's tons of acronyms for this, but the one that sticks with me the most is just knowing your alphabet. Because who doesn't
Mhm.
know their alphabet, right? That's like
Yeah.
the basics. So this part of the alphabet is OPQRST. If you can
Okay.
remember OPQRST, you can get all the data very quickly from your patient. So,
Hmm.
for example, like Pony, if you were my patient and let's say you had shoulder pain, I would ask you the O, which is, when did this happen? The onset. The O is for onset. When did this happen? And how often do you feel this complaint? Is it 24 hours a day or does it come and go? If it comes
Hmm.
and goes, how long does it hang around for? Those kind of things. So that's the
Hmm.
O. The P is palliative and provocative. Palliative means, soothing to the palate. So something that makes you feel better. So, Pony, what makes your shoulder feel better? What makes it feel worse? The other part of the P is provocative. Like
Hmm.
these are essential questions because if you tell me it feels worse at night when you're sleeping, I already know there's something wrong with your sleeping position that needs to be corrected.
Hmm.
Those kind of
Right.
things. If you tell me heat feels good, then obviously you're going to feel good when you leave. When I use infrared heat, Moxa, hot pack, we already know
Hmm.
what's going to help. So the next thing is the quality and the quantity. So, the quality of your pain tells us a lot. Is it sharp, dull, achy, burning, throbbing, etc.? The nature of
Hmm.
pain gives us some clues. And then we can go to the quantity, which is like 0 to 10. How is your pain right now in this moment that you're talking to me? And then how is it at its worst in the last 24 hours? How is it at its best in the last 24 hours? So that's how we could use that pain scale a little more accurately. And then the R is OPQR. So OPQR, the R is radiate. Does it radiate anywhere? Is your discomfort localized, or does it go to a different area of your body? And this is important not to lead the patient. So if someone comes in with sciatica, I don't say, does the pain radiate from your back down to the bottom of your foot? Like you wouldn't lead the patient. You got to
Yeah.
like leave the questions open. Like, does your pain go anywhere else? If so,
Mhm.
where and how often? And then T is time. Is your symptoms worse during a certain time of the day, morning, afternoon, or night? If you say you keep waking up in pain, I know something's going on with your sleeping position, or maybe you have some arthritic changes, and they get better as you warm up. So it already gives you a lot of clues. But what you see is a lot of people don't gather that data when they present case studies and things. And
Mhm.
and the subjective information is key. Like you already have a clue, like a very good clue of what the problem is before you ever laid hands on the patient if you do that OPQRST. And now when you get into the rest, the physical exam, you're again just trying to prove or disprove your hypothesis.
Right.
So if I
Right.
tell you, hey, Pony, I think you have a rotator cuff tear, and this is the reason why you have these symptoms, but then you have these data points, and it's like proving a case to yourself, holding yourself accountable versus like, well, I just heard that pain there means you could have this, like, or when I press here, it hurts. Like that's
Mhm.
not enough data. We need to be more. We need to raise the bar on our level of practice.
Mhm. That's great. Yeah. I definitely think that if one does a very good history, um, oftentimes, with enough clinical experience, you're already kind of starting to funnel in. You're just doing one or two orthopedic tests to confirm.
Hmm.
So a good history taking can actually, in a way, it seems like time consuming. People might not want to do it, but it's actually the
Hmm.
opposite. If you do a good history taking, you end up having to hone in faster, and you're going to be more efficient in your practice. Actually, it's actually a little counterintuitive, not the other way around. um, um, like for example, uh, I like the accountability discussion, because here's the thing. Obviously, as a practitioner, we always we sometimes deal with patients that are more difficult. They say, "Oh, the pain's still there. The pain's still there." Yeah, but it's like 10% of what it used to be, right? So,
Right.
you can't make a yes or no. You have to, many ways to quantitate it or qualify it, right? To
Exactly.
refer or not refer. So this is how as a practitioner is working, but also sometimes the patient needs help knowing that too, because to them it's like yes or no,
Yep.
right?
Right.
And yeah, and now the weird thing is that um, the opposite can happen. Sometimes they can not be getting better, but they have so much trust in you. They
Right.
say they
I
are better,
know.
right? That
That's
happens too. So these
yes.
tests go both ways. It actually helps you if it's actually better or not, even though the patient might say it's better, but it actually may not be, right?
That
So
is that's a good point.
yeah, yeah, I know. So like,
They don't want to hurt
yeah,
your feelings. They want to say,
yeah.
"Oh yeah, you're doing a good job.
No,
I'm
but
getting
some, but
better."
yeah, but sometimes, I mean, because there's the report, there's the placebo effect, the
Mhm.
attention being heard, maybe we just I keep putting needles, we help them to sleep and their stress levels better. So indirectly things have gotten better, but right, but
That's
maybe the
true.
range of motion didn't get better, that sort of things. But if you didn't take the time to do these assessments, then you're not really truly helping the patient, right? So
Yeah.
I'm such a big fan of these more objective measures, and so I hope I have a chance to take one of your classes in the near future.
Thank you. Yeah, likewise. Yeah, I mean, the objective things is amazing because it's really the whole story. Like if you don't do that, you're missing half the story. It's like going to the movies and walking out halfway through. You never even found out what the ending was, like by
Mhm.
doing these things, like you said, you hold yourself accountable. You can see the full presentation. And something that I've been really like just kind of blown away is that the more you do this, you start to understand your patient, the person in front of you better. You understand how they hurt themselves. And then as you treat them and they start to get better, you're able to have a better picture onto, how to teach them how to prevent themselves from
Yeah.
getting hurt again. It's like with
Right.
back pain, I've been seeing so much radiculopathy in the last few months. I think from all these people working at home, sitting too much and things.
Yeah.
But it's always like, their sleeping position, their sitting position, or their
Yeah.
standing position, how they stoop and twist and things. And then if you can identify the activities for them and show them how to move a little better, it's like, wow, these patients that have had pain for, 11 months, over a year, nothing's helping them. After a couple of visits, all of a sudden they just shift. It's like,
Hmm.
wow, okay, those are the patients that are listening to your advice, and then, your acupuncture treatment or whatever treatment you're doing is going to hold better. It's going to have a better lasting effect because they don't just go home and immediately do the thing that was causing their injury to begin with. So it's so vital. And before I forget too, one of the things that I think is really important is clinical experience. So,
Hmm.
we always talk about, okay, people like to talk about how many patients they've seen, but I look at it as like, how many push-ups can you do? You can probably do 100 really lousy push-ups, but could you do like 10 really good ones? And I think that's the same with treating patients. Can you treat
Hmm.
10 patients really good? And if you can, I think your clinical experience is going to be so much more profound than treating 100 or 1,000 patients very quickly without getting all
Hmm.
that data, getting that feedback, and seeing what your input, what your needles are actually doing. So the more
Hmm.
you go deeper, you get a richer, more fulfilling experience that it's going to help other people more down the road.
Hmm. Actually, I find, um, a lot of times the patients that come to our practice um, have gone through the conventional healthcare system, which is not known for spending time with their patients, right? So,
Right.
you remember how many times patients say to you, "Oh, they say that, oh, you know more than my neurologist, or you know more than my surgeon." It's not that we know more than them. It's just that we actually take the time to ask questions and do the assessments. So, but
Yeah.
but for whatever it's worth, that time the demonstration of your knowledge and doing the testing, listening carefully, it's actually building rapport and confidence. So they're already ready to be needled and treated by you,
Right.
right? That's a big part of the efficacy. I think that
Oh, for
that
sure. Yeah.
yeah, like like you explain what's going on, why is referring, for example, right? And this is why I'm going to treat you here, even though your pain is there, but I'm going to needle you here. That that you lay out in very logical progression, and they puts them at ease and comfortable with you, right? And
Right.
I think that goes a long way to that rapport building is huge. And
Yeah,
I think that's
absolutely.
a yeah, and I think that's one value of a good history or assessment taking, that is it's not just a left brain diagnostic thing. It actually can become a right brain emotional and relationship building kind of thing.
Absolutely. I had a patient yesterday, and she was telling me that she went to another acupuncturist and she had a bad treatment. And then,
Hmm.
so I'm naturally gathering data all the time. So I said, well, what defines a bad treatment to you? I want to know because
Hmm.
I don't want to repeat those mistakes.
Yeah.
And so, basically, she went in for back pain. The practitioner said, so what's going on? You have back pain? Okay, let's have you lay on your stomach, needles in, needles out. After she gets off the table, okay, have a nice day.
Hmm.
Never once said anything else. And I don't want to, I'm not saying that that's bad. I mean, been treated by amazing practitioners that can do that. But what I'm saying for us, for the majority of people, taking the time to actually figure out what's going on with the person and letting them know that you know what you're doing is profound versus the shotgun approach where I just do protocols or recipes for every person, and then you depend on that. So when it works, great, you're the hero, you feel so good about the experience. But when it doesn't work, you have no idea what to do next. And then
Hmm.
it goes back to what you're saying, like, that rapport. But what I see is it comes down to trust. Like, your patients need to
Hmm.
trust you. And if you know what you're talking about and you can explain it to the patient on their level, you can see that trust right away. I mean, I had a new patient yesterday. I didn't even put needles in yet, and he's already trying to refer me people. I haven't even treated him yet. It's because he had 4 different complaints, and we were able to, like, okay, here's what's this. And he's like, hey, you know where my problem's coming from. He's like, can I
Hmm.
send people to you? Like, I haven't even treated him yet. But the trust is already there.
Yes. So the take home
Yeah.
message is that do good assessment, do good history, and it'll lead to more referrals.
More trust. It will lead to more
More trust.
trust, and that'll lead to more referrals.
Yeah. Let's talk about common mistakes that we make in our clinical examination history taking process. As an instructor, you um, must see this a lot. Can you help give us some ideas of what are some things that we can do better? What are some common examination mistakes? Like I thought you mentioned, for example, don't say, "Does your pain start from here or refer there?" Like don't coach
Yeah,
them. That's one, right? Anything else that you
right.
can let us know?
Yeah, for sure. There's a ton, obviously, and I,
Mm,
I make mistakes all the time and learn from them. But I say the number one mistake is to assume anything. So if you start assuming things, you don't leave room for error. And as you get experience in this profession, you become very aware that nothing is always right. So you always see people say, "Oh, that treatment works like a charm. That treatment works every time." That no, it doesn't.
mhm,
Like there's no perfect of anything. So I wouldn't jump on the thing and say you have a rotator cuff tear based, I'm certain of this. For me, I like to say, well, these things suggest the possibility that this might be going on, but I could be wrong. And
mhm,
but we're going to treat it like that, and we're going to keep reassessing as we go. And if what we're
mhm,
doing is working, great, let's keep doing it. If it's not working, we're probably missing something. Leave the door open for mistakes, because you're gonna make mistakes every single day. And if you're at this level where you don't make mistakes and you feel like everything works like a charm, um, you have to check yourself. You have to hold yourself accountable and get back to this understanding that there's no two people that are exactly the same, and you could be very wrong about this person in front of you. I mean, I had a person with a supposedly a rotator cuff tear who had cancer in his shoulder, and it took
mm,
the doctors a while to figure out that there was a tumor in there. But if I learned
yeah.
a valuable lesson from that experience, because if I was in private practice, he was getting better with acupuncture. He was a swimming teacher, and he was getting his range of motion was getting better. He was getting stronger, less pain. He was doing good. Unfortunately, there was cancer in there, and I did not. There's no way I would have known it. I would have thought that, hey, okay, you're doing good, discharge you.
Mhm,
So I mean, never assume anything in this business. Um, so
mhm,
that's a big mistake. I think another big mistake is to jump on a bandwagon. So you learn a couple of assessment tools and you think that's all that there is. You need to continue to go deeper. It's not one thing. If you do manual muscle testing, for example, that's a great tool, but that's not your entire picture of that HORSE acronym. That's one little sliver, and you need to incorporate as many of those pieces as you can to develop an educational guess that supports your hypothesis. So if you only
mhm,
have one little sliver of information and you go, oh, okay, your problem is this because this muscle is weak or whatever, you are missing the bigger picture. So I would say, keep learning. Like never get satisfied. You got to go deep. And if you want to try to get better at something, what I found helpful for me is just pick a body part. So, like for example, I keep saying shoulder because it's on my mind, but if you go to, let's say, I want to learn shoulders, you can learn
mhm,
shoulders really easily. I mean, the technology is in your hand, the anatomy is in your phone. Just take some
mhm,
notes, right? But then what you need to do is just fill in the blanks of that horse. So, what kind of questions should I ask someone who has a shoulder problem? There's some specific questions that can help
mhm,
guide your diagnosis. If you've got pain at nighttime, that's a very common symptom of rotator cuff tears. When it wakes you up from your sleep. It doesn't mean you have a rotator cuff tear if you wake up from sleep, but it's just one more data point or one more clue. If
mhm,
what do you see when you look at a patient who has a rotator cuff issue? What is their range of motion going to be like actively, passively, resisted? And then what special tests can help differentiate two competing diagnoses? So maybe there's like, oh, I think it's this or this. Well, there's going to be some tests that can be used that differentiate that. And then when it comes to palpation, that's our expertise. But just know what's underneath your finger. You got to get in there and know how to differentiate. Well, if I palpate LI15 with the arm resting on some, like if my hand's on my belly and I press on LI15, I'm touching the supraspinatus tendon. But if my hand is out to the side on the table with my palm to the ceiling and I press LI15, I'm more likely pressing the biceps tendon now. So it's just like little subtle things like that they're so basic, but when you apply them, it seems like it's advanced, but it's really not. So those are some common things off the top of my head, but there are a lot of things that we do wrong, and there's still a lot of things that I do wrong. But I think maybe the worst thing you could do is stop learning.
Hmm.
keep being motivated because we're helping people, and we're in this profession that is bridging this gap between surgery and everybody else that's not helping these patients. Like, we are on the
Hmm.
front line, and acupuncture is that effective. It blows my mind every day, but we have to have a way to test how effective it is, to get that experience that I was talking about that helps us to be better, and then share that information freely with your colleagues so everybody's better. I think that is one
Hmm.
of the best things we can do as a profession, and I hope we can, get there.
Certainly, I think if we all up our own game by becoming better at doing assessments, it will transform the prestige and
Yeah.
the reputation of our profession for sure, right? Like the it's um, now I we're running out of time, but I have to pick your brain. Okay, I want you can you share like a clinical pro with us? I always like to do this. Something that perhaps you're really good at treating. You're talking about shoulders today. Anything about
Yeah.
shoulders or something like that? That
Yeah.
some assessment or diagnostic advice you can give us so that we can maybe try it out, or maybe something that we're not thinking in that way, and give us a different thinking cap to help us look at the body or assess the patient. Any advice for our fellow listeners and viewers today?
Sure. My lead in will be that, there is this, like, movement where people are saying, special tests, orthopedic tests are not good. Those
Mm,
people, unfortunately, have not done the research. And it's much easier
mm,
to say it's not good than to dive deep and learn it, because it takes a long time to really understand all these things. And I know because I've been going through it. But one thing that I've been doing in the last year is digging in and picking apart all the research and starting to pick out, tests that have been proven time after time to be effective, and how effective those tests are, like at
mm-hmm,
changing your post-test probability of someone having a problem. So no, orthopedic tests are not bad. Yes, they're great, but you have to understand how to utilize them. So a really simple clinical pro for shoulders is, if somebody tries to raise their arm over their head but they can't, and they end up shrugging their shoulder into their ear, based on the research, they are 15% more likely to, if they can do this without shrugging their shoulder, they're 15% less likely, I should say, to not have a rotator cuff problem. So people who can raise their arm easily and freely, you know, that's, they could still have a rotator cuff issue because people are asymptomatic and so forth. But when you see somebody shrug their shoulder into their ear to try to raise their arm, what that tells you right away is there's something wrong with their shoulder. It doesn't tell
mm-hmm,
you what it is, but what they've narrowed it down to, it's either the rotator cuff, it's frozen shoulder, or they have arthritis in the joint. So that there's a high probability that somebody has a shoulder issue if they put their shoulder in their ear to try to raise their arm over their head and they can't
mm-hmm,
raise it all the way. And then, as a side note, let's say you're that person that can raise your arm easily, but you can't bring it down very easily. Like, you have to bend your
mm-hmm,
elbow to shorten the moment arm so that it's not as heavy. You end up bending your
mm-hmm.
arm, or you support it to bring it down. That starts showing you, like, okay, this person, is more likely to have a rotator cuff issue. And that sign alone changes the post-test probability by 15%. So what does that mean? Wow, that's a lot of information. But what they've shown is the number one risk factor for rotator cuff injuries is age. And if you're 60 years old, you're 25% more likely to have a rotator cuff tear if you come in saying my shoulder hurts. So 25% of those people have rotator cuff tears. If that person has a hard time lowering their arm, now you add to that 25% an extra 15, and you go, whoa, this person is 40% likely to have a rotator cuff tear going on. Just with that information alone. I didn't even ask them any questions. I didn't do an intake. I didn't do the other tests. Just those two pieces of information alone, he's 40% more likely to have a rotator cuff tear. He's 60 years old and he can't lower his arm without bending his elbow
Mm-hmm.
and supporting it. So
Yeah.
these tests, when you use them like that, they can give you some, good clues to support your hypothesis.
Thank you so much. I love that because a lot of times people look at things like on the on the way up, right? Or doing the activation part, but they don't look at the entire process. There's another 50% of it is when they put themselves back into the neutral position, and that part you mentioned where they with they're shortening their arm. Like if you just turn around to do your charting, you would have missed
You
that
missed
completely,
it.
right? Yeah.
That's a
So
good point.
yeah.
Yeah.
So I really you gotta really watch the entire process. I really love that. So thank you very much. I learned so much from you in this short amount of time that we have for today. Where
Thank
can
you.
the rest of us go if we want to find out more information about your courses? Do you have any contact information, website, social media? Where can we go if we want to study more with you in the future?
You can check out the Facebook group discussions on acupuncture orthopedics.
Hmm.
DAO, DAO is the acronym to make it easy to remember because I love acronyms.
There you go, acronyms. Yeah.
and then,
Yeah.
and then I have my website. It's www.orthopedic-acupuncture.org. Orthopedic-acupuncture.org.
Thank you so much, Jamie. It's been a pleasure. It's been an honor
Thank
to
you.
finally meet you virtually face to face. Thank you very much
Likewise.
to thank you very much to our fellow viewers, and don't forget to join us next week when we're going to have my fellow host Regina Duran giving us another excellent show.